Hello, my name's Jason Bedford. I'm a specialist in endodontics. I work in practice in Solihull and in Leicester. You've made your diagnosis, you've explained to the patient the options, they've chosen to go ahead with the root canal, you've shaped the canals, you've cleaned the canals, you've disinfected the canals, now it's time to obturate. So in this course, we're going to talk about why we obturate, the materials available, the techniques available, with the aim of giving you some ideas and to help you choose the technique that's suitable for your patients and for your practice. As you can see from these x-rays, some people are good at obturation, some people are not so good at obturation, some people are a little bit too good at obturation, and some people don't really understand the influence that obturation can have on the outcomes of a case. This lady, for instance, was referred to us because the root canal in the upper left lateral was a little short. We can make that root canal as long as you like, and it isn't going to have any bearing on the outcome for this poor patient. The first study of interest is by Sabetti et al. In 2006. It was carried out in dogs. They took a whole load of root canals, they shaped them, they cleaned them, and they provided a coronal seal. Some of the canals were filled and some of the canals weren't filled. They reviewed the cases at 190 days and found absolutely no difference in the healing rates between the two cases. Whether they were filled or not filled had no bearing at all on the degree of healing. Their conclusion was that the elimination of bacteria, the provision of a coronal seal, were far more important steps than the obturation in achieving success. A second study, also in 2006, but this time in monkeys, took a whole load of root canals, they shaped them, they cleaned them, they filled the canals, and then they reviewed them 2 years later. They found that when they sampled the canals for bacteria at that 2-year point, the success rate of canals where they found no bacteria was up in the 70-odd%. A success rate where they did find bacteria inside the root canal dropped down to 28%. And that was regardless of the quality of the obturation. Importantly though, when they did look at that group of where the healing wasn't quite so successful, so there were bacteria present, where there was a good root filling as opposed to a poor root filling, the success rate in that group was significantly higher. So to summarise these studies, if we can eliminate bacteria from the root canal, and if we can provide a good coronal seal that prevents reinfection, we will get healing. However, as you can see from images like this, the chances of us completely eliminating bacteria from a root canal are very slim, particularly in complicated root canals. So obturating as well as we possibly can improves the healing rate because there will inevitably be bacteria still present in a root canal. So really we should think about our obturation as extending our coronal seal, creating a block to the passage of bacteria down back into that root canal, but also creating a 3-dimensional obturation that prevents recontamination of the bacteria that are inevitably left behind. The other reason, of course, is to identify teeth that have been root filled, and the quality of that obturation offers an indication of the potential for success to future observers. Of course, if your livelihood depends on referrals from local practitioners, then also creating pretty pictures is quite important. Some elements of obturation are still controversial. The timing of the obturation, the length of the obturation, the materials used, and the methods used. So we're just going to run through some common questions and common issues surrounding obturation. The first is timing. When should we obturate? Ideally, we should obturate once we've got that canal shaped, cleaned, and disinfected. Whether that's done in one visit or multiple visits is often cause for debate. I think the most important study was done by Manfredi et al. As part of a Cochrane review in 2006. They reviewed all of the evidence and could find absolutely no difference in the radiographic signs, the incidence of failure as measured by extraction, or the immediate post-op pain or intervisit flare-ups or post-visit flare-ups between single visit and multiple visit treatments. They did, however, find a low level of evidence for increased post-operative pain in the first week after treatment. But of course, patients who are only having one visit only get this once. There are exceptions. If you have very wet canals, if you're uncertain about the prognosis or the diagnosis, or if you simply run out of time for a complex case, you might want to temporarily obturate that tooth and perform the treatment in multiple visits. If you are going to do multiple visit endo, what should you temporarily obturate a tooth with? The gold standard is calcium hydroxide, non-setting calcium hydroxide paste such as Sure paste. It can be quite tricky to get the paste down to length or to fully obturate the canal. You can use spiral fillers, need to use those with care, they have a nasty habit of fracturing. You can use a GP point to pump the sealer down to length, or you can, most of the non-setting systems come with a syringe. If you really struggle to get the calcium hydroxide paste down to length, and then at the second visit to remove that calcium hydroxide paste, it's worth considering using calcium hydroxide points. I would use them in combination with the paste in order to use that point to deliver the paste down towards the apex. I wouldn't necessarily use them on their own, but if you use them in combination with a non-setting paste, it makes it easier to place the calcium hydroxide, and it's really simple to remove at the second visit. The evidence base for using other materials to temporarily obturate a canal is really quite poor. So the traditional methods of using phenols or steroid-based pastes or chlorhexidine, there really doesn't have a solid foundation in the evidence base. So generally I would stick to calcium hydroxide. One thing that I would definitely advise against is using a paper point, whether it's medicated or not. Using a paper point inside a canal between visits. The number of patients I've seen who have had 3, 4, 5, 6 visits to their practitioner, and this tooth just simply won't settle. And when you open it up, you find that wet paper point inside the root canal. All it does is just wick fluid in from the surrounding tissues and just make life more difficult. So if there's one takeaway message from this course is, don't put a paper point in a root canal in between visits. Many of us will be using a cotton wool pledget just to keep the canals open and to provide a reference point for when you come back to that second visit. If you're using cotton wool pledgets, I'd recommend giving PTFE tape a go. It's cheaper than cotton wool, believe it or not. It's easier to place, it's easier to remove in one piece, and you don't get those annoying strands of cotton wool either coming out through the filling or getting in the way when you come back to your second visit. Simply taking a 3 or 4 millimeter stretch of PTFE tape and folding it down into the root canal is a much easier way of trying to keep those canal orifices open, but also providing a nice base for your temporary filling. The second controversy is how long should the root canal filling be? Should it be long? Should it be short? Should it be flush at the apex? What's too long and what's too short? The team at the Eastman in 2011 looked at the prognostic factors for success in root canal treatment. They identified 4 conditions that improve the potential outcome significantly. First was the preoperative absence of a periapical radiolucency. Then a root filling with no voids. A root filling extending to within 2 millimeters of the radiographic apex. And, probably most importantly at all, a satisfactory coronal restoration. If we look at the European Society of Endodontology quality guidelines, they recommend that the prepared root canal should be filled completely, unless there's space for a post needed. There should be no space between the canal filling and the canal wall, and there should be no visible root canal space beyond the apical extent of the root filling. So in general, we want to prepare as close as possible to the apical constriction, and you might want to look at the video we have on apex locators and working length to go into that in more detail. The apical constriction is short of the radiographic root terminus in many cases, so our preparation will inevitably be short of the radiographic root terminus. That means that our obturation will be short of the radiographic root terminus. The key, though, is that there's no visible root canal beyond the extent of our obturation, even if it does look short. Here's a case that we can see where we have a lesion of endodontic origin, distal to this lower left 5, quite a big area of periapical radiolucency, and the tooth has been treated, and it does potentially look short. As you can see, though, 6 months on, we have a beautiful degree of healing, and I'm sure that tooth will go on and provide service for many years. There are some exceptions. For completion, and at the risk of complicating matters, studies would suggest that in cases with preoperative periapical pathology, either short or flush with the apex has a similar outcome. The challenge, of course, is assessing the true relationship between your GP point and the apical foramen and the radiographic root terminus, which is a 3D relationship, and we're looking at things on a 2D X-ray. So, use your apex locator, establish a good working length, and fill to the full extent of your shaping. The next controversy is the material that we use. Generally, we're using a core material and a sealer. The core materials, for the main part, is still gutta-percha. Gutta-percha, or if you prefer, trans-1,4-polyisoprene, was first discovered or first documented in 1843 by Dr. William Montgomery. It's produced from the sap of the Palaquium gutta tree from Malaysia. Interestingly, in exactly the same year, another discovery was made, which was the fax machine. So gutta-percha has lingered along when fax machines have probably died out. But if you read this article from the Plastics Historical Society, they will tell you that ultimately the development of synthetic plastics made gutta-percha virtually obsolete. Today, its sole commercial use is in dentistry for our gutta-percha points. There have, of course, been lots of attempts over the years to replace gutta-percha as the mainstay of our root canal fillings. I'm going to focus on two recent products that attempted to replace gutta-percha. Primarily because the concepts that they were based upon were sound, even if they didn't turn out to be commercially successful products. The first product was launched in 2004 and was Resilon. Resilon consisted of resin points and a bondable sealer called Epiphany. The idea was that your sealer would bond to your dentine, the sealer would then bond to your resin points. You'd create a monoblock from crown to apex, completely preventing the movement of bacteria and fluid. Unfortunately, it appears that this bond that was proposed was inconsistent, and recent studies by Barborka in 2017 and more recently by Strange in 2019 suggested that that bond was inconsistent and didn't lead to long-term success. The Barborka study looked at 100 teeth over 5 years and found nearly 6 times higher failure rate. Strange's study of 125 teeth again found a 5 times reduction in success rates. Another issue is, of course, cost per case. Gutta-percha is incredibly cheap, and all of these systems end up adding significant cost to the treatment. The second product, launched in 2007, was called SmartPoint, or ProPoint, and still available in the US as C-Point. This system consisted of a point which was made of a nylon core wrapped in a hydrophilic polymer. This polymer would absorb fluid from within the root canal that's naturally present and slowly and gently expand in order to fill any of the intricacies of the root canal. The important thing with this system was that it was paired with a bioceramic sealer. So you had an expandable point and a bioceramic sealer. The sealer would bond to dentine, and the hydrophilic point would push it into all the little nooks and crannies within the root canal. The C-Point wasn't ultimately successful, but bioceramic sealers have persisted, and we'll talk about those later. So gutta-percha persists as the mainstay of what we use. It's low cost, there's good long-term results, and it's easy to use. Or does it? If you look at modern GP points and you look at their constituents, for instance, the Wave 1 Gold GP points should probably actually be called Wave 1 zinc oxide points. They consist of 49.5% zinc oxide, only 23% gutta-percha, and then the rest is made up of barium sulfate, which gives its radiopacity, and fillers and colours. And that list of constituents is common across most GP points. There's actually not very much GP in them. A common question we get around gutta-percha points is whether there is a risk of latex allergy. Gutta-percha itself does not contain latex. According to the American Latex Allergy Association, there have been 2 reported cases of gutta-percha allergy in latex-sensitive individuals. However, in both cases, it would appear that other products probably caused the reaction. Given the high number of root canals done, in the UK it's around about 3 million each year, in the US it's around about 40,000 a day, and the prevalence of latex allergy in the population, which is rising, this low incidence of reaction suggests that the risk is very, very small, if it's present at all. However, patients with an allergy to latex may well be sensitive to a whole host of products, and in particularly sensitive individuals, it may well be worth liaising with their allergy specialist when considering what materials to use. The next area of controversy is around the obturation technique to be used. These have changed massively over the years, and we'll run through some demos of currently available products and materials towards the end of this course. If you look back at the history of obturation techniques, you'll see that they very much mirrored developments in instrument technology and the philosophies around shaping root canals. In the early days, life was easy. Root canals were round and straight, files were thin and round and straight, and so our obturation points needed to be thin and round and straight. And silver points became popular. It made sense. Silver was antibacterial. It could be drawn into long, round cones, and I still see them today. In a well-cleaned canal with a silver point in place and a good coronal seal, they can function for many years. You will still see cases today, and advice really is that in the absence of any periapical pathology, signs or symptoms, the simple presence of silver points alone is not an indication for retreating that case. Soon, obviously, it was realised that root canals are only ever round in textbooks. They're more often ovoid and very irregular. Sealers that were used around silver points and single cones generally would break down and dissolve, and you would end up with the whole canal becoming recontaminated. We also started to consider the concept of canal taper in preparations, and at the time GP points didn't have any taper. So the best way forward was to minimise the amount of sealer available and use multiple GP points to pack into the root canal and condense them into these often irregular shapes. And obviously that became cold lateral condensation. That became the norm and is still the basic technique taught in dental schools to this day. Over 50 years ago, though, Herbert Schilder recognised that cold lateral condensation, while quite useful in the coronal and middle third of the canal, really didn't do anything to help seal the apical portion of the canal or the lateral ramifications that we find inside the pulp space. He used a series of heated pluggers, measured sequentially up through the root canal, and took little aliquots of gutta percha and worked from apex to crown to fill up that root canal. For the first time, we started to see a three-dimensional obturation created, as witnessed by the radiographic appearance of lateral canals being filled and little sealer puffs exiting through complex portals of exit at the apex of a tooth. Schilder's vertical compaction of warmed gutta percha technique fulfilled all of the requirements for the ideal three-dimensional obturation, except for one. It's devilishly difficult to do and really difficult to do well. In the early 90s, we started to see the introduction of rotary endodontic files. These files enabled the creation of much more taper to a root canal. Unfortunately, the inherent limitations of instruments at the time meant that multiple files had to be used, and we ended up with sometimes quite considerable taper, particularly in the coronal part of the canal. While this was much easier than hand filing, the taper was often quite exaggerated, particularly coronally. These wider tapers were actually really quite difficult to obturate with cold lateral condensation, and with Schilder's technique being so difficult, a new technique was required to give us that three-dimensional obturation in such wide root canals. System B, launched by Stephen Buchanan, sought to overcome these problems. The system involves a series of heated pluggers, which allows you to pack GP down into the root canal much more quickly, much more efficiently than the Schilder technique, but still achieving that three-dimensional obturation. In order to complement the down pack achieved by the System B unit, the Obtura gun became popular. And the initial versions looked very much like a glorified glue gun, but it's still in use today by endodontists globally, and we'll see some new versions of the original Obtura gun later on. There are cordless versions. There are all sorts of variations on that theme now available, but they all utilize the same method, namely a down pack and a backfill technique, commonly known now as continuous wave condensation. As rotary instruments start to become more popular, all sorts of systems were developed, and most systems these days have a matching GP cone system. So you have a tapered GP cone which matches beautifully the taper of your final root canal instrument. The issue with this, as we can see from this photo, is that these GP cones match the taper so well that there's now no room really for cold lateral condensation. So cold lateral condensation in these cases is almost obsolete. If you are using a cold technique with a single cone, we are wholly reliant on the sealer that we're using, and those sealers haven't really developed much since the days of silver points. So the challenge there really is that we are back to that same issue that we had with silver points, where we have a central cone and a potentially soluble sealer that we're relying upon. These matched tapered GP cones have really made cold lateral condensation obsolete. The only way really that we can use those cones is either with a heated technique or to re-look at the relationship between our sealer and our cones. As we said previously, obturation techniques tend to follow from preparation techniques. As with many areas of dentistry, endodontics is now embracing minimally invasive preparation techniques. We're starting to see a new breed of rotary and reciprocation instruments that have much narrower taper than previously. The aim being to try and reduce the amount of coronal dentine that's removed from the root canal and giving back a degree of strength to these teeth that can have an increased risk of fracture. So you start to see instruments such as TrueNatomy from Dentsply, which was launched at the IDS in March 2019, and I understand will be available soon in the UK. But also you're starting to see the files are narrow, the gutta percha points are narrow, the paper points are narrow, the irrigation needles are very narrow. And this is going to pose a challenge for obturation. The GP points will match beautifully, but potentially the heated pluggers that we might use with our downpack and backfill technique might struggle to heat that apical portion of the root canal, and potentially we may need to look at a different way of obturating root canals, particularly based around these bioceramic sealers that are becoming popular. And then, of course, we have completely novel ways of shaping root canals. Products like the self-activating file, which relies on a mesh that expands into the ramification of the root canal to debride the walls, creating or leaving a very natural shape to the root canal, which isn't easily obturated with a standard cone. Or something along the lines of the sonendo technique, which uses vortices and an acoustic microstreaming in fluid to debride and gently shape a root canal. Again, creating very natural shapes to the root canal, which aren't easily filled with traditional techniques. The second element to our obturation system, along with the gutta percha core, is our sealer. Traditionally, sealers have been resins such as A8+, or zinc oxide based, such as Grossman's or Kerr pulp canal sealer or Tubulacil. They might be calcium hydroxide, such as Sealapex or Apexit, or glass ionomer, such as Ketac Endo. The good news is there is absolutely no evidence that any one of these sealers is any better than any other, and the choice really therefore boils down to personal preference, ease of mixing, radiographic appearance, and I guess price as well. The ideal properties of a root canal sealer were originally proposed by Louis Grossman. I've updated these to change some of the language, but if we look at the properties that he proposed, a root canal sealer should adhere to GP points and to the canal wall. It should make a hermetic seal. It should be radiopaque. It shouldn't shrink on setting. It should be bacteriostatic. It should set slowly to give you plenty of working time. It should be insoluble in tissue fluid and biocompatible. It should also be soluble in a common solvent in order that the case could be retreated if needed. In addition to the traditional sealers, we now have bioceramic sealers. These were developed from the original work done on the original endodontic bioceramic MTA, or mineral trioxide aggregate. There are several now on the market, and they're all based on differing combinations of zirconium oxide, calcium silicates, calcium phosphates, and calcium hydroxide. Some of them come in pre-mixed syringes, some of them come in a powder liquid mix, and you also get putties, which are useful for repairing root canal defects. There are also now heat-resistant versions, which can be used with your downpack and backfill heated techniques. When we're looking at bioceramic sealers, what we're really doing is redefining the relationship between gutta percha and sealer. As we can see from these images, the original concept was that we would have multiple gutta percha points packed into the root canal with a thin layer of sealer surrounding each point and lining the walls of the root canal. As we moved towards warm vertical compaction, we ended up with a dense, solid central core of gutta percha with a thin layer of sealer surrounding it. And that's true for our downpack and backfill obturation. Carrier-based devices, we end up with a central core of either plastic or nowadays cross-linked gutta percha with a surrounding core of gutta percha and again a very thin layer of seal. Conversely, if we look at our tapered gutta-percha points, we find that we are back to the point where we have a central core of gutta-percha, circular in this case and not well condensed, with a thicker layer of traditional sealer trying to fill up the voids. When we look at bioceramic obturation, we see a complete switch in the relationship between sealer and gutta-percha. Now we have a sealer that provides the bulk of the obturation with a central GP core that is used to distribute the sealer around the root canal and also provide a route to retreatment should you need it. If we look at the properties of bioceramic sealers, many of them mimic those original ideal properties as suggested by Grossman. So they do bond to dentine, they bond to some kinds of GP points as well. They do create a nice hermetic seal, they're ready opaque. They get marginal expansion on setting, certainly no shrinkage. Most of them are white, so the risk of staining is low. They're antibacterial when setting and have a long setting process, so they're antibacterial for quite some time after being used, and then they're bacteriostatic afterwards. They have a long setting time, about 15 hours in some cases, and they have high levels of biocompatibility. One issue with bioceramic sealers is the potential for difficulty when retreating. That's why we need to use that central core of gutta-percha, which enables us to access down into the root canal. And in my experience, any sealer that is left in the canal is readily removed with hand instruments or ultrasonic tips. So bioceramic sealers are easy to use, have very low cost of entry. They're completely compatible with all of your current shaping systems and your obturation technique. And probably more importantly, they're very useful for some of the new ways that we're seeing of shaping root canals with minimally invasive approaches or sonic or self-activating type files. They've been around for quite some time now. They were first launched back in 2007. Recent studies, Chabowski in 2008 looked at 300 teeth over a period of 30 months, and he found a 91% success rate. Interestingly, he showed that 47% of cases showed some element of sealer extrusion, but this had absolutely no effect on the outcomes. A more recent study was a survey of over 2,000 dentists in France and the US. 95% of respondents were aware of bioceramic sealers, and 50% of respondents were actively using bioceramic sealers. So it would appear that these are becoming increasingly popular. What we're going to do now is look at some obturation techniques. I'm going to give you some tips and tricks on some basic and some more advanced techniques that you can use in the practice. Regardless of which obturation technique you're using, you're likely to be using a master GP cone. Traditionally, we would try that GP cone in and take an X-ray to verify the fit. Sometimes when you try your GP cone in, you'll find that it comes up short. If that's the case, simply re-irrigate, run through the file sequence, maybe with your master apical file, just to make sure there's no debris down at the apex, and then retry that GP point. If you find it's still coming up short, sometimes it's feasible just to go back down to a slightly smaller size GP cone and try that. But here's a scenario that I'm sure you're all familiar with. You've established your working length with your apex locator or an X-ray. You've done all the shaping and cleaning to that length, and now you try your GP point in. So in this case, we're working to a working length of about 19 millimeters. So we measure our GP point to that working length. Using an endo ruler, we see that it's 19 millimeters, and we try that into the canal. On this occasion, it slides nicely down to that working length and to our reference point. So we take our X-ray, confirm that fit, everybody's happy. We pop that GP point out, canal. Apply a little bit of sealer, pop it back into the canal, maybe wiggle it around a little bit to get the sealer distribution around the canal. Condense down to get a nice three-dimensional fill. And we take our post-op X-ray, and it's gone long. Now the reason that GP point went long was because of a discrepancy between the size of the apex, the size of the master apical file, and the size of the GP point.
So here's a tip. Don't measure your GP points before you put them in. Place the GP point in as far as it'll go into the canal and only measure it on the way out of the canal. Now when you measure your cone, you'll see that it's not 19 millimeters, or it's not at your working length, it's gone long. In this case, it's gone long by a couple of millimeters, 21 millimeters there on the endo ring. So we'll cut it back by approximately 2 millimeters, using either scissors or a scalpel, and we'll try it in again. Again, we're not measuring it at this point. We're just placing that GP point into the canal as far as it'll go. On this occasion, we got it right first time, but you may need to repeat that process. But we check the length again on the way out rather than on the way in, and find that yes, we're at our working length of 19 millimeters. Now when you try that cone back in, you'll feel that it goes to working length. There's a little bit of resistance at the working length, and you can condense either cold or heat as hard as you like on that GP point, and it won't go long. Equally, when you just pull back, you'll feel a little bit of resistance to removal. We call that tug back, and that shows that you've got a nicely fitted cone down at the apex, and this is compatible with pretty much every obturation system that you'll come across. Once you've placed your GP points by whichever method, you're likely now to have to cut that GP back. Traditionally, we'd use a heated instrument using a Bunsen burner or a hot air blower or even a cigarette lighter. There is a much easier way. Most of you will have an ultrasonic scaler in the practice. Any ultrasonic tip will do. Simply turn off the water to the handpiece, put your foot on the foot pedal, and as long as you keep your foot down on the foot pedal, the tip will be active and it acts as a heated plugger. You can use it also to condense the GP down into the canal. As I say, any tip will do. Here we have a selection of tips, a standard scaler tip or a couple of endo specific tips, but any tip will do. The rule of thumb is that if you have to screw your tips into your handpiece, it will work for this technique. Cavitrons don't work as well, but any EMS or Action, Satellec, Woodpecker type ultrasonic handpiece can be used for this technique.
There are several versions of these devices on the market. The one we have today is a cordless version, but regardless of which system you use, they consist of a pen-like device that heats removable pluggers of different sizes. Place the tip into the heated pen and activate the heat. This works between 150 and 180 degrees. Activating the device activates the heat at the tip of the instrument, which allows you to pack GP down into the apical portion of the canal. The clever bit with these devices is that they cool almost instantly, which means that the GP no longer sticks. So we can use the heat to pack down into the canal, release the heat, and it doesn't stick to the GP. The second element of the system is the extruder. These guns heat pellets of gutta percha up to between 150 and 220 degrees. When you gently press the trigger, you get gutta percha extruded from the fine needle, which allows you to quickly and easily backfill the coronal portion of the canal. Here's a demonstration of the warm vertical compaction technique. The first thing to do is to try in your plugger to about 4 millimeters, 5 millimeters from your working length. Having tried that plugger in, we fit our GP cone as described previously, take an X-ray to verify its position. Next, we take a small amount of sealer on the tip of the GP point and just use that to coat the canal with a liberal layer of sealer. We then take our heated plugger and activate the heat and cut off the GP point at the canal orifice, just packing it gently down into the canal with a normal plugger so that we've got a nice plug of GP to pass the heated plugger through. We activate the heat of the tip and just gently press that plugger down towards that 4 or 5 millimeters from the working length, and you can see how the sealer and GP is packed and condensed into the canal. We keep the pressure on for a little while, and then a short burst of heat and a wiggle, and we withdraw the plugger, bringing out the excess coronal GP. Using a standard plugger, we now pack the GP down into the canal, scraping it off the walls in that coronal part that hasn't been condensed. It's important to not bounce that plugger, but to firmly press and keep pressure on that GP as it cools and condenses so that we don't get any shrinkage. If you were placing a post, that's you done. However, in most cases, we're going to now backfill that void that we've created using our extruder or our GP gun. We gently rest the tip of the heated instrument against the apical plug, squeeze the trigger, and extrude that GP back towards the coronal orifice. Again, we can tidy that up now with a standard plugger, just plugging it down into the canal. And you have a nice three-dimensional obturation, very quick, very efficient, and you get great distribution of the cedar and GP into all the ramifications of the root canal. You can now place glass armour or composite, your core material of choice, over that GP plug, and you're done. So, in summary, there are several methods available for a predictable three-dimensional obturation of root canals. Research repeatedly shows that endo success is achieved when we locate all of the canals, we shape and clean the whole system, we obturate to the full extent of the shaping, and we provide a coronal seal. Due to the multifactorial nature of endodontics and the fact that there is no evidence that one obturation system is any better than any other, it makes sense to select your obturation system on the basis of something that works well in your hands, is compatible with the shaping and filing system that you're using, or future filing systems, and of course is cost effective for your type of practice and the type of teeth that you're treating.